It's now my pleasure to introduce Elizabeth Hudson from the state of Wisconsin.
Good morning, the state of Green Bay Packers and cheeseheads. Although I will say I grew up in a household that you were grounded if you did not root for the Redskins. So there, I do have a sense of community here. So I additionally come to you from the University of Wisconsin School of Medicine and Public Health. It's where I'm employed. But my primary work is as a consultant to the Department of Health, the Wisconsin Department of Health Services. And before that position, I had worked for pretty much 20 years on and off as a domestic violence and sexual assault advocate, in addition to a clinician working with very young children impacted by trauma. In the many years that I've done this work, the most persuasive piece of information I think I've come across in communicating the impact of trauma has been what is called the Adverse Childhood Experience Study. And there's always a few nods in the audience that we recognize the importance. It's so interesting, you know, almost 20 years later, it's now becoming extremely important within the world of our policymakers. So I did want to give some information about the ACE study, then to follow up on Commissioner Samuel's mention of the brain and give some brain basics, and then give just a little bit of information about trauma-informed care, because it is something that we're engaged in within the state of Wisconsin and quite excited about. All right, so the ACE study, for those of you who haven't had exposure to that, you've got, pardon me, your issue briefing, and within the briefing, you'll be able to reference quite a few slides that will give you some of the more detailed information. And there's also, if you Google CDC ACE study, you'll be directed to quite a rich amount of information. But just to summarize what this important ACE study gave us, I want to bring you back to Dr. Vince Folletti, who we know is the person who really started this process of examining the correlation between adverse childhood experiences and later behavioral and health issues. So as Vince Folletti explains it, he is a physician working at Kaiser Permanente in the San Diego area, and he was quite interested in the prevention of obesity and addressing severe obesity. So he put together a program that was very effective. People were losing weight. They were losing dramatic amounts of weight. And what was of interest to him was there was a group of folks who were dropping out, even though they were very successful. So it got him thinking, what's going on? Let me ask a series of questions. He states he really has no idea what he was looking for with the set of questions he put together. One of the questions happened to be, did you experience childhood sexual abuse? With that question, he found a high correlation of people who had dropped out of the study and had lost weight. So it got him to re-examine his assumptions about what the problem was. He started to consider perhaps the obesity, the eating dysregulation, et cetera, is not the problem, that that's a response and that it's a strategy of coping, et cetera. So what they did then is they considered, okay, well, let's think about other adversities that people experience. Now, let's go back to the group that he has to work with. It's 17,000 people. Okay, so if you're a researcher, you're pretty excited. You got 17,000 people in your research study. The population is about 65% over the age of 50 years of age. They're predominantly white, and they have insurance. They're employed. It looks that most of them have graduated high school, and the majority have had exposure to a college education. Okay, so this is an interesting group. And the Center for Disease Control got wind of the possibilities here, and Rob Anda the co-principal, now referred to as the co-principal investigator for the ACE study, joined with Vince Folletti. And they put together what we can look at as 10 questions, and those are listed on your first, within the briefing on the first Adverse Childhood Experiences PowerPoint slide. When they talk about having collected this information, Rob Anda, who we're grateful has done quite a bit of work in Wisconsin to educate us on this study, he talks about when he got the results and he saw that over 2/3 of the population that they surveyed had experienced at least one adverse child experience, category of experience, and that 1 in 6 had experienced 4 or more. He said he walked into the elevators at Kaiser Permanente and he started to cry because he was a physician and had been one for many years and had never fully understood the lives of the people that sat before him as a physician. He had always looked at what the problems were, what the symptoms were, what the diseases were, but he hadn't understood that there were this underlying history that people brought with them. In particular, they were really taken aback when you look at the population base. This was the folks, as Vince Folletti says, who made it. These weren't the folks that many people can say, well, it happens to that group, or it doesn't happen to us, it's those people over there, because this was us. This is the people in this room. So it raised the awareness that there is a high level of prevalence, and then what it did is it allowed us to start looking at the correlative factors of these 17,000 folks within the research study, and how with each additional category of abuse, which they're listed here, some of them include physical abuse, emotional abuse, neglect, domestic violence, living in a household with addiction, etc. So with each additional category of abuse came the higher probability that there would be a correlation to a multitude of both behavioral issues as well as disease states. So we're looking at a high correlation between the indiscriminate sexual behaviors that we often see lead to things like HIV/AIDS. We have the use of alcohol and other illicit drugs that can lead to things like liver disease and heart disease, smoking, the relationship to COPD, etc. So you get the gist that there's a high correlation between these behaviors that for a long time we've just looked at as quote-unquote bad behaviors. These are just things, people just say no, just stop, just quit doing those things. Now we're understanding that for many people these are coping strategies. These are ways to address underlying issues that have happened before the age of 18. You also have in your briefing a pyramid, which I think does a nice job of summarizing this study and gives you a tool, equips you to go out and spread the word about the impact of these early adverse experiences. So it takes you up the pyramid from at the bottom, the adverse childhood experiences that I've mentioned. There's also a survey in your packet, so you can walk out of here, make your whole week, and see how many ACEs you have. Then I'm going to skip the red level, which is disrupted neurodevelopment, and take you up to impairment. So the reason I skip the disrupted neurodevelopment is I'm going to bring us back to that. And that indeed has been the newest piece of this pyramid. When this study was first initiated, we really weren't able to point to a causation. There was purely correlation. So then we move up to social, emotional, and cognitive impairment. Again, I'll take you back to disrupted neurodevelopment and explain how we think that's operating. When you live with impairment in these domains, it makes sense that you adopt what we'd call health risk behaviors. So if you're trying to deal with a dysregulated nervous system, you're going to use a lot of different strategies that might be alcohol and other substances. It might be relational engagement. It might be more aggressive behaviors, again, due to the regulation issues. When you are engaged in those behaviors, the next piece of the pyramid makes a lot of sense, too. Disease, disability, and social problems, right? So by social problems, we can talk about juvenile justice, corrections. The tip of the pyramid is a piece that is, for many of us, most daunting. It says early death. What they're finding is those folks who are living with 6 or more categories of adversity experienced before the age of 18, on average, are dying 20 years earlier than people with 0 adversity. So this has huge implications, as you can start to connect the dots with how we address our public health issues, the cost of health care, what we could do to be preventing many of the social conditions that lead to so many of our human services. So again, very persuasive piece of information. I encourage you to spread the word. All right, I'm going to bring us back to this part of the pyramid that I referred to as disrupted neurodevelopment, because I think that that is one of the pieces of information that has allowed many of us who have intuitively known there are these connections, right? We've been doing this work for a long time. We know people suffer from health conditions and behavioral issues, but we didn't have the connecting piece. We think we have a significant piece of that now. We're just starting to learn about it, and that has to do with neurobiology. And I'm going to do a very quick brain basics. It's quick mostly because that's about as far as my knowledge goes, but I also think it's another handy tool when you're talking to people about the impact that this kind of adversity can have on the developing neurobiology of our children. So I referenced Dan Siegel, who has done some amazing research in the work of attachment and trauma, as well as some other very interesting areas. In his book, Parenting from the Inside Out, he asks us to think of this very simple model of the brain. He says, think about this is the spinal column, this is the brainstem, the limbic system, and the frontal cortex. So there you have this simple model of the brain in the palm of your hand. What we know about kids who come into, infants who are born into the world is they have, 100 billion neurons. And they're basically all the neurons that we're going to have in our life. And it's their job and our job to help them create the neural connections and the pathways as they develop. So we're one of the few species where we come into the world not ready to live on our own. We require relational connection in order to create the structure that will allow us to function well in the world. So I would like to, and I apologize, we have sort of a limited screen here, but I'm going to show you a 3-minute clip of that relational dance that we see happen with very young children and mothers. And this is the work of Ed Tronick, who is going to describe what is called the still face experiment.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, come on, why aren't we doing this? Even in this 2 minutes, when they don't get the normal reaction, They react with negative emotions. They turn away. They feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
It is actually quite helpful for our young children and our adults to experience stress. This is what builds our resilience and our capacity to handle things in the world that are hard. But it is that assurance that there will be a reconnection and a restabilization of the infant system and the young person system. There will be the outside environmental capacity to help that child regulate because their neural systems are not developed to do it on their own. Without that, when we start to see, here's an instance where this is a child that can absolutely withstand 3 minutes of a flat affect. Now let's think about the children that are exposed to parents who have addiction issues, as we mentioned in the ACE study, one of the adversities. Parents who are unavailable due to imprisonment. Environments that are very chaotic, that are filled with physical abuse, domestic violence. Imagine that infant having to figure out how to regulate by the figures in that situation. And that way we can start to understand how this brain that is developing from the bottom up, coming into the world largely, with all our neural connections, but with the overriding drive to create the limbic system and the frontal cortex that will become connected enough. When we talk about this brain, the limbic system is really the sensory responsive part of the brain. The frontal cortex is the thinking, logic, executive functioning, language piece of the brain. So if we are, as we know, developing from the bottom up, if this regulatory part of our brain, the limbic system, which has got all of the capacity to remember smell, touch, taste, tone of voice, body posture. If we can't get this to the point where it's solely focused on survival, the ability to really start making those important connections with the frontal cortex, those opportunities are not enhanced. And that's where we start to see some of the many difficulties that I talked about with social, emotional, and cognitive impairment. It's a lot of information to take in and hard to package it in a short period of time. But in a sense, we have the opportunity as children develop to help make sure that their brain architecture, their immune system, their cardiovascular functioning are set on a path of health. If we allow the kind of disruptions to occur and we do not promote that health, we're looking at what appears to be a lifetime of struggle with the capacity for a very early death. So it becomes quite imperative when we look at the research together. So in Wisconsin, what have we started to do? No, we are not knitting little baby booty bootstraps and saying, figure it out, little ones, pull yourself up by those bootstraps. It seems absolutely ridiculous, right, to even think that that would be a direction that people would go. But in many cases, it's what we ask parents to do, it's what we ask adults to do, is pull yourself up by your bootstraps. With this new science, we're starting to look at this as a mental injury, one in which people may not, without the right skills, without the right approaches, without the right assistance, be able to do that. It would be like asking someone to run a marathon who had a broken leg. Just do it. Just do it yourself. What we are looking at within Wisconsin is a trauma-informed approach within all of our human service systems. So we have got connections now within the Department of Corrections, Department of Children and Families, Department of Health Services, Department of Public Instruction. Because what we're saying is what kids need, if they're not going to get it in their homes, is immersion into health, connection, attachment, and safety. Trauma-specific interventions, those specific mental health strategies that are often funded, can be quite helpful, but they're never going to be enough. It's not practical. It's not even appropriate for all people to be engaged in mental health services. But what we can do is create systems of care as well as communities that get this information and say, I'm going to commit to making attachment, safety, the assistance of the regulation of kids' nervous systems one of my priorities. So I thank you so much for allowing me the time to speak to you, and we'll move on. Catherine.